So in 1735, there's this surgeon in London, and he successfully removes an appendix from an 11-year-old boy.
Which is incredible for the time.
Right. But the really wild part, he had absolutely no idea what an appendix was. I mean, the actual disease we call appendicitis wouldn't even be invented for another 150 years.
That's flying totally blind.
Exactly. Welcome to today's deep dive. If you're joining us, our mission today is decoding the hidden language of surgery. We are digging into a stack of clinical terminology notes and historical timelines to basically unpack this clinical powerhouse of a suffix, which is cholecystectomy.
It really is a fascinating piece of language because, we tend to view medical jargon as this impenetrable wall of code, like it's designed to keep patients in the dark.
Oh, 100%. It feels very gatekeepery.
Right. But once you understand the actual machinery of how these specific words are built, a hospital chart completely transforms. It turns into a set of, highly readable, logical instructions.
Okay, let's unpack this, because I've always thought of the medical dictionary as something you just have to brute force memorize, like flashcards.
Yeah, a lot of people do.
But looking at our sources for today, it's actually much more like a set of Lego blocks. You have the root, which tells you the specific physical body part, and then you have the suffix, which tells you what's being done to it.
That's the exact formula. And for this particular block, the ectomy suffix, it comes to us from ancient Greek. The root word is ectomy.
Okay.
And it's actually a compound built from two smaller pieces. You have ek, meaning out of or out from, and temnen, which means to cut. So you put them together and you get...
To cut out.
Exactly, to cut out.
So applying the Lego block method here, you take an out for a body part, say the appendix, you snap on that appendectomy block, and boom, you have appendectomy.
Right.
Tonsil, snap on the block, tonsillectomy. You instantly have this billable, codable surgical procedure.
Yeah.
I mean, it feels very clean, very absolute.
It does feel absolute, but there's a trap there. We really need to clarify a major misconception right off the bat.
Oh.
Yeah, because the textbook definition actually hides some serious clinical ambiguity. The word extractomy implies a kind of totality that just isn't always physically there.
What do you mean?
Well, it strictly means cutting out. It does not inherently mean removing entirely.
Wait, really? Because I feel like if someone tells me they had a gastrectomy, my brain immediately assumes their entire stomach is just gone.
And that's exactly what most people assume. But physiologically, if you have a partial gastrectomy, a surgeon is only removing a diseased portion of the stomach.
Oh, I see.
They remove that part and then reconnect the healthy remainder so your digestive tract still functions.
That makes sense.
Or, consider a lobectomy. Using the root for lobe, a surgeon might remove one single lobe of a lung, or maybe a wedge of the liver, or even half of the thyroid gland. They are deliberately leaving the rest of the organ behind so it can keep doing its job.
So the actual extent of the surgery isn't baked into the suffix at all?
Not even a little bit. The suffix only tells you that a scalpel was used to separate tissue from the body. To know the actual scope of the surgery, you have to look for a modifier in the chart. You're looking for words like partial, total, radical, or segmental.
Wow, that drastically changes how you read a diagnosis.
But okay, as I'm looking at this Greek root, ectome, wait a minute. If this is ancient Greek, that means people like Hippocrates and Galen were using it, right?
Yes, the words existed.
But they obviously weren't doing partial gastrectomies or liver lobectomies in ancient Athens.
Definitely not.
So when did this vocabulary actually become the global standard for the modern operating room?
To understand that, we really have to look at the medical revolution of the 19th century. As Western medicine started to professionalize, you suddenly had doctors training in Edinburgh, Vienna, Paris, and they needed a precise, universally understood language.
Right, to communicate.
Exactly. They needed to be able to read each other's surgical case reports without crucial anatomical details just getting lost in translation. So they reached back to the classics. Because Greek and Latin were basically nobody's native conversational tongue at that point.
Which is brilliant, if you think about it.
Yeah, it removes all the local slang and the colloquialisms from the equation, making the words feel purely clinical and neutral.
Precisely. But this standardization, it exploded in the late 19th century for a much more practical, frankly grim reason. This vocabulary boom only happened because surgery finally became survivable.
Survivable. Right, because we really do take for granted that before the mid-1800s, Opening someone's abdomen was essentially a death sentence.
Mostly,
I
yes.
mean, you didn't need a word for an operation you couldn't successfully perform.
Exactly. What's fascinating here is that the vocabulary we use every day now, words like thyroidectomy or nephrectomy for kidney removal, they could only be coined when patients could reliably wake up and heal.
Which took a while.
It did. Mechanically, that required two monumental breakthroughs to solve two different biological crises: systemic shock and rampant sepsis.
Okay, the pain and the infection.
Exactly. The first was anesthesia. When William T.G. Morton demonstrated ether in Boston in 1846, it solved the nervous system's response to the agony of the knife. The patient wouldn't just die of pain-induced shock.
Right. But I mean, ether doesn't stop bacteria.
No, it doesn't, which was the second crisis, and that took another 20 years to figure out.
Wow.
Yeah, in 1867, Joseph Lister introduced antiseptic technique. He was literally spraying carbolic acid around the operating room to kill microbes, building on Pasteur's germ theory.
So before those two interventions, attempting to cut out an internal organ almost guaranteed a fatal systemic infection.
Pretty much. Once surgeons could reliably put patients to sleep and keep bacteria out of the wound, they started attempting and succeeding at all these internal excisions. That specific late 19th century window is when our modern orlecectomy vocabulary is truly born.
Okay, so the vocabulary stabilizes in the 1800s. But reading through the historical timelines in our sources, the actual story behind how these individual surgeries evolved is wild.
No, it's incredibly chaotic.
Yeah, it's not a clean, logical progression at all. It's full of accidents and massive overcorrections. Like if we look at the appendectomy story from the beginning of the show, the timeline of the action and the timeline of the word are completely disconnected.
The Claudius Amiens story from 1735 is a perfect example of that. He was operating on a hernia in an 11-year-old boy.
Right, he opens up the hernia sac and finds the appendix inside it, completely punctured by a pin the boy had somehow swallowed.
Which is just a freak occurrence.
Totally. So Amiens cuts it out. The boy miraculously survives without anesthesia or antibiotics, and history is made. But as you mentioned, the concept of appendicitis, like an inflamed appendix that needs to be removed before it ruptures and fills the abdomen with bacteria that didn't exist.
It didn't exist for another century and a half. A Boston pathologist named Reginald Heber-Fitz didn't coin the term appendicitis until 1886.
1886.
Yeah, he used autopsy findings to prove that early surgical removal was the only way to stop the infection from spreading.
So Amiens performed the mechanical action by pure chance. But the routine clinical practice and the word itself are late 19th century inventions.
Exactly. And, if Amiens' appendectomy shows us doing the right surgery at the wrong time in history, the history of mastectomy is almost the dark mirror to that.
How so?
Doing an overly aggressive, biologically flawed surgery, but having it become the undisputed gold standard anyway.
Oh, man. This is the story of William Stewart Halsted in the 1880s at Johns Hopkins.
Yes.
He developed the radical mastectomy. And just to clarify, radical in surgical terms means extremely extensive.
Very extensive.
Mhm.
Halsted was operating on the best theory he had at the time, which was that breast cancer spread outward in a predictable, continuous physical line, a contiguous crawl through the nearby tissues.
I see. It's like viewing cancer as a rot spot on an apple. If you just cut a wider margin around the rot, you completely remove the threat.
That was the exact logic. So, to get that wide margin, the radical mastectomy removed not just the breast tissue, but the underlying pectoral chest muscles and all the axillary lymph nodes under the arm.
That sounds brutal.
It was physically devastating. It left patients with severe mobility issues. Yet, because of Halsted's massive influence in the medical community and the intuitive logic of that rot on the apple theory, it became the absolute dominant standard of care in the English-speaking world for the next 80 years.
80 years of generations undergoing this massive intervention.
Yeah.
Until someone finally questioned the underlying mechanism of the disease.
Yes. In the 1970s, a surgeon researcher named Bernard Fisher ran these large, rigorous, randomized controlled trials. Fisher proved that breast cancer doesn't just crawl outward in a continuous line.
It doesn't.
No. It's a systemic disease that often spreads microscopic cells through the bloodstream and lymphatic system very early on.
So returning to the analogy, it's not a rot spot on an apple. It's more like a weed in a garden.
I like that.
Like, you can dig a massive crater trying to pull out the weed and all the soil around it. But if the seeds have already traveled through the underground root network, digging a bigger hole where the weed originated doesn't actually help.
That is a brilliant way to conceptualize it. Because of that biological reality, Fisher proved that a less physically destructive surgery, a lumpectomy, which is basically a partial mastectomy to remove the primary tumor, combined with systemic radiation or chemotherapy to catch the seeds in the network that produced equivalent survival rates.
That is such a profound takeaway for anyone navigating the medical system today. The suffixectomy tells you that tissue is physically extracted, but it tells you absolutely nothing about how much tissue was actually biologically necessary to remove.
That's spot on.
The surgical vocabulary can remain exactly the same, while the scientific consensus completely flips.
Absolutely. So the mastectomy history shows us figuring out how much to cut. But if we look at the cholecystectomy, the removal of the gallbladder, we see a total revolution in how we cut.
Right, because from the 1880s up until the late 1980s, removing a gallbladder meant a major open surgery. A large abdominal incision, cutting through muscle, a long hospital stay, and weeks of painful recovery.
And then the mechanical approach completely changed. In 1985, a German surgeon named Erich Mew performed the first laparoscopic cholecystectomy.
The keyhole surgery.
Exactly. Instead of slicing the abdomen open, the surgical team pumps carbon dioxide gas into the abdominal cavity to inflate it like a balloon, creating a physical workspace. Then they insert narrow tubes called trocars through tiny keyhole incisions.
Right, and they slide a fiber optic camera and long, thin instruments through those tubes, detach the organ, put it on a tiny surgical retrieval bag, and pull it out through one of the keyholes.
It's elegant.
It completely transforms the physical experience of the patient. You go from weeks of agonizing recovery to potentially going home the same day. But the fascinating part to me is that the word on the patient's chart didn't change at all. It's still just a cholecystectomy.
It perfectly illustrates that the term names the final outcome, a gallbladder, was separated from the body, not the method used to achieve it.
But sometimes a surgical technique gets so streamlined and culturally accepted, we end up doing it when the biology doesn't even call for it. Which brings us to the tonsillectomy.
Ah, yes. The classic T&A surgery, tonsils and adenoids. By the mid-20th century, this was plausibly the most common major surgery performed on children in the U.S. During peak years in the late 1950s, we are talking upwards of 1 million of these procedures annually.
It was basically a childhood rite of passage. You get a sore throat, you get your tonsils out, you get to eat ice cream for a week.
Pretty much.
But looking at the sources, this massive volume was driven by a fundamental misunderstanding of the immune system, right?
Right, it really was. The prevailing thought was that tonsils were essentially useless vestigial organs, just fleshy traps for bacteria. Doctors assumed that proactively removing them would generally reduce colds and upper respiratory infections.
So just take them out before they cause trouble.
Right. But as immunological research advanced, the medical community realized tonsils are actually the immune system's first line of defense. They are lymphatic tissue actively sampling bacteria and viruses that enter the mouth to help build immunity.
Wow. So doctors were preemptively cutting out the body's alarm system.
In many cases, yes. The medical community realized they were vastly overestimating the benefits of the surgery and underestimating the physiological role of the tissue.
That's a huge shift.
Today, the indications are much narrower. It's usually reserved for severe, heavily documented recurrent infections, or if enlarged tonsils are causing obstructive sleep apnea. It's still a highly effective operation when applied correctly, but its mid-century history is a textbook example of surgical overuse driven by strong cultural momentum rather than strong biological evidence.
We've seen how technology and evidence shift the scale of cutting, like with the mastectomy, and the method of cutting, like with the laparoscopic gallbladder. But reading through the modern clinical notes in our sources, there is a fierce debate happening right now about what happens when technology gets so advanced that we aren't even cutting anymore.
Yes.
We're talking about the boundary between excision and ablation.
This is where surgical terminology gets incredibly tricky. Doctors today have tools that sound like pure science fiction.
They really do.
They use lasers, cryoablation probes that freeze tissue to death, or high-intensity focused ultrasound that cooks tissue from the inside out. They can destroy a tumor or a problematic fibroid entirely in place at a cellular level without ever physically extracting it from the body.
So the tissue is essentially vaporized or left to be reabsorbed by the body, but it's never pulled out and put in a specimen jar.
Exactly. So medical purists argue these procedures absolutely cannot be called altecectomies because the Greek root temnein literally requires the physical act of cutting something out.
Makes sense.
But colloquially, in hospital hallways and even in some patient charts, you'll see the language blur. A doctor might say they ablated the tissue, but casually refer to the overall procedure using an appendectomy shorthand.
And according to the coding manuals in our sources, this isn't just an academic debate about Greek translations. This has massive financial teeth.
Oh, it certainly does. Professional medical coding systems, like the CPT codes used for billing in the United States, are incredibly strict about this physical
Oh,
distinction
why?
because ablation destroying tissue in place and excision physically removing it involve different equipment, different risks, and are reimbursed by insurance at completely different rates. If a chart says an appendectomy was performed, but the mechanical procedure was actually an ablation, that is a severe medical billing and compliance issue.
So the insurance companies absolutely care whether the Greek suffix matches the physical action.
Yeah. They do. And if we connect this to the bigger picture, it underscores why learning these suffixes empowers you as a patient. To read a surgical chart like a sentence, you can't just know cholecystectomy. You need to know its siblings, the neighboring terms that also share that temny root for cutting, but denote completely different physiological actions.
Okay, let's test this. I've got the terminology notes in front of me, but let's see if we can mechanically break these down based on what we've learned. Let's start with otomy. O-T-O-M-Y.
Mechanically, otomy means cutting into something to gain access without removing the structure itself.
Like a tracheotomy. You are slicing an incision into the trachea to create an emergency airway hatch, but you are absolutely not removing the windpipe. You're just creating a temporary doorway.
Exactly. Now, what happens if we change it to ostomy? O-S-T-O-M-Y.
Based on the roots, this is creating a permanent or semi-permanent port. It's fundamentally rerouting the body's plumbing.
That's the perfect way to describe it. A colostomy is a prime example. A surgeon brings a portion of the colon through the abdominal wall to create a stoma, which is an opening.
Right.
They are bypassing the lower digestive tract and rerouting the biological transit system to an external pouch. It's not just an access hatch, it's a new anatomical exit.
Got it. Okay, next up is oscopy.
This one is primarily diagnostic. It means looking into a cavity or organ with a fiber optic scope equipped with a camera.
Like a colonoscopy or an endoscopy. You're exploring the territory, though you might do a tiny bit of housekeeping, like snipping a polyp while you're in there.
Precisely. And finally, we have leplasty.
Shaping or molding. It's surgical reconstruction. Like a rhinoplasty reshapes the cartilage and bone of the nose. It definitely doesn't remove the organ wholesale.
Exactly. So if the anatomical root word tells you where the surgical team is working, the suffix tells you the precise mechanical action they are performing. It really is a highly specific sentence.
But misreading that sentence leads to massive societal misunderstandings about some of the most common surgeries in the world. Which brings us to our final section. Clearing up common physiological misconceptions.
These are so important.
If you're listening to this and you've had a vasectomy, or maybe you are thinking about one, the biology here is fascinating because popular imagination gets it entirely wrong.
It is incredibly widespread. Given how the word sounds, the electomy part, many people assume a vasectomy either removes the testicles entirely or severely disrupts the body's male hormones.
Let's explain the actual mechanism here because it's a brilliant piece of biological engineering. The testicles have two main jobs. They produce sperm and they produce testosterone. But they ship those two products out using entirely different logistics networks.
That's exactly right. The testosterone travels through the endocrine highway. It gets absorbed directly into the bloodstream. But the sperm travels through a physical muscular tube called the vas deferens, the reproductive highway.
So during a vasectomy, the surgeon is only snipping and sealing a tiny segment of that physical tube, the vas deferens. They are essentially just snapping the cargo train tracks. It does absolutely nothing to the Wi-Fi network of the bloodstream.
I love that analogy. Mechanically, the testicles remain perfectly in place. Because the bloodstream is untouched, testosterone production and libido remain completely unaffected.
Which is a huge relief for a lot of people.
Absolutely. Even the physical volume of the ejaculate is practically unchanged because sperm only makes up a tiny microscopic fraction of that fluid. The rest comes from other glands.
But what happens to the sperm the body is still producing?
The body handles it the same way it handles any dying cell. Specialized immune cells, called macrophages, simply break down and reabsorb the sperm tissue. It is a highly localized, highly specific procedure that society has mythologized into something much larger and more destructive.
That distinction is so cool. Okay, misconception number 2 involves the female reproductive system. Hysterectomies and menopause. I've heard this constantly, that having a hysterectomy throws your body immediately into surgical menopause.
This is another major misunderstanding of which anatomical factory does what. A hysterectomy, by definition, strictly means the removal of the uterus. That is the incubator, the organ where a fetus grows. But the uterus does not control menopause?
It doesn't.
No. Menopause is driven by the rise and fall of hormones produced entirely in the ovaries.
So if a surgeon removes the uterus but leaves the ovaries untouched, the hormonal factories are still running.
Right. Removing the ovaries is an entirely separate biological procedure called an oophorectomy. Now, it is true that sometimes an oophorectomy is performed at the exact same time as a hysterectomy.
Which is probably where the confusion comes from.
Most likely. But if a patient keeps her ovaries during a hysterectomy, she will continue to produce estrogen and progesterone. She will reach menopause at her natural biological age. She just won't have a menstrual cycle anymore, simply because there is no uterine lining left to shed.
Differentiating the incubator from the hormone factory is so critical for patients making permanent decisions about their bodies. And the last misconception, which we touched on earlier with the gallbladder, is the miss of the giant scar.
Yes. The lingering cultural assumption that an uretectomy automatically implies a massive open-air abdominal incision, a huge zipper scar.
Historically true, but completely false today. Because of the laparoscopic and robotic revolutions, the vast majority of many colectomies, gallbladders, appendixes, increasingly kidneys, and colon surgeries are done through those tiny, inflated keyhole ports.
Right.
The suffix on the chart remains exactly the same, even though the physical trauma to the abdominal wall has been reduced by 90%.
It's astonishing progress.
So we've tracked this from ancient Greek roots to the bloody pre-anesthesia operating theaters of the 1800s, through the debates over lasers and billing codes, down to the actual cellular biology of modern surgery. Why should you, the listener, care about the mechanics of the anatomy suffix?
Because almost everyone is going to encounter this specific word at some point in their lives, either for yourself or a loved one. Appendectomies and tonsillectomies are incredibly common childhood occurrences.
Definitely.
Cancer-related excisions like mastectomies or prostatectomies, these are heavy, complex conversations happening in living rooms every single day. Knowing this vocabulary turns you into an empowered, active participant in your own healthcare.
So what does this all mean? It fundamentally changes the questions you bring to the consultation.
Exactly. It prompts you to ask sharper, more precise mechanical questions. If a surgeon recommends an ectomy, you now know the suffix doesn't equal totality. You can ask, is this a partial or total removal? You know the debate over methods, so you can ask, is this being done by physical extraction or by ablation?
Yeah, you know what to look for.
And perhaps most importantly, remembering the history of the radical mastectomy versus the lumpectomy, to ask, is this historically established surgery actually the right size biological intervention for my specific body today?
You're no longer just nodding along to an encrypted language. You're actively reading the code.
Yeah.
And I want to leave you with one final thought to mull over. Building on that massive technological shift we talked about, we've seen how innovation shifted the atherectomy from a brutal open-air operation to a tiny laparoscopic keyhole, and now to high-intensity ultrasound that literally vaporizes tissue in place without taking anything out of the body at all.
Yeah.
So look forward. As genetic engineering, targeted immunotherapies, and even microscopic medical nanobots become our new clinical reality, will the very concept of physically cutting out a diseased piece of the human body eventually become entirely obsolete. 50 years from now, will the atherectomy suffix be nothing more than a linguistic fossil, a reminder of a much more barbaric medical age? Something to think about next time you're staring at that hospital chart.